Winestone, please invite you to begin. And please speak loudly and clearly into the microphone.
All right, so I'm honored to be here today to share our results related to socioeconomic disparities in survival of children with newly diagnosed acute myeloid leukemia, or AML, as I'll refer to it throughout the presentation. Just to give a little bit of background, about 20% of pediatric leukemias are acute myeloid leukemia, and this therapy is delivered in hospital, and so removes the concerns about potential adherence that may differ by the population. We used 2 clinical trials through the Children's Oncology Group, which is an NCI-sponsored member of the National Clinical Trials Network. And those 2 trials, AAML 0531 and AAML 1031, are phase 3 clinical trials that enrolled 2,327 patients, which represents one of the largest cohorts of AML across pediatric and adult settings, actually. So to give you a little bit of background about what has been done in this area in the past, adult studies have previously shown conflicting results and have largely been either single center or used registry data. There is one clinical study that used the California Cancer Registry, and that study actually incorporated children. The population that it examined was patients from the age of 0 to 39, and so pediatric patients accounted for about 43% of their population, and so their results are particularly relevant in terms of thinking about background. So they found that 15 to 30% increased risk of death among patients from the poorest neighborhoods relative to patients from the wealthiest neighborhoods. And similarly, when they looked at early death or death during the first course of chemotherapy, they found a 57% increased risk of early death among patients from low income or poor neighborhoods relative to the higher income neighborhoods. In addition, in that study and several others, the lack of insurance or public insurance have been associated with inferior survival as well. So to give you a little bit of information about our study population and how we defined high income, low income, and poverty patients, high income patients were defined using census data, so we linked the clinical trial data to census data using zip code and found that patients who had an income 2 times the federal poverty line, or about $56,000, were in this category. The low income category was 1 to 2 times the federal poverty line, or somewhere between $24,000 and $56,000. And then the poverty group, you can see, is quite small, but their neighborhood median household income was less than the federal poverty line for a family of 4, which is $24,000. So just to highlight some of the differences, perhaps not surprisingly, we found that patients who were Black were more likely to reside in an impoverished neighborhood or a low-income neighborhood. Similarly, Hispanic patients were more likely to be living in poverty or in a low-income neighborhood. And then, again, perhaps not surprisingly, because Medicaid is based on your income, we found that patients who had Medicaid only or public insurance were more likely to live in poverty or in a low-income neighborhood. So here we present our first finding related to event-free survival, where events include both relapse or recurrence of AML and death. Show here that there's a very substantial and stark disparity between those that live in poverty and those who live in a middle or high income neighborhood, with 54% of patients in a middle or high income neighborhood surviving, and only 34% of those living in poverty surviving or not relapsing. Similarly, when we look at overall survival, we see a similar disparity with substantial differences in survival between middle and high income relative to the low income and poverty populations, with 68% of middle to high income patients surviving, 61% of low income patients surviving, and 43% of patients living in poverty surviving. When we looked at a multivariable model where we accounted for other significant factors that impact survival, we found that in particular, the middle and high income patients have a 27% lower risk of dying. And in addition, well-described previous racial disparities persist even when social factors and socioeconomic status are accounted for, suggesting that there may be other factors that are contributing in addition to socioeconomic status. When we look at treatment-related mortality, we find that there are more deaths from treatment toxicity among patients from low-income areas. So again, here you see that low-income patients have about 11% dying between the second course of chemotherapy and the end of chemotherapy, where only 3.7% of patients in middle and high-income areas die from the same types of toxicity. So in summary, overall, this is the first national evaluation of socioeconomic status in an exclusively pediatric cohort. And we found that more children with AML from poor neighborhoods relapse, and that more children with AML from poor neighborhoods die relative to patients who live in higher income neighborhoods. And this data certainly highlights a stark disparity, but requires more data, particularly related to individual socioeconomic status, to determine how to address these disparities and really target interventions so that we can have equitable care across the population.